I might just add that one other point is that as time goes on, the question is going to come up more and more, who's paying for all of this? Rituximab is not a cheap drug. Okay, let's go on to Velcade, bortezomib. Is there any way to prevent Velcade's tendency to cause peripheral neuropathy? Mr. Gertz, do you want to start that one out? This end?
I think the most important thing is surveillance by the treating practitioner. I think that intense questioning before every dose, whether someone's beginning to develop numbness in their toes or pain or discomfort. I think this is one area where prevention is important, but prevention by assessing each symptom. Now, there have been a lot of different attempts in terms of scheduling the dose down from 1.6 to 1.3 to 1.0. There's been frequency changes from twice a week, 2 weeks out of 3, to once a week, 4 weeks out of 5. Very recently, in myeloma, changing the bortezomib or Velcade use from an intravenous injection to an under-the-skin injection reduced the risk of grade 3, grade 4 neuropathy from 16% to 6%, and then, which is, I think, a very, very important issue. And then the final thing is there have been a number of genetic studies now that do sequencing for single-chain nucleotide polymorphism, sorry about the jargon, that actually can identify those patients who are uniquely predisposed to develop the bortezomib neuropathy, and they sometimes can be then the subject of either intense scrutiny and surveillance or alternatively immediate dose and schedule modification from the beginning.
Steve?
So I agree with all that Morrie has shared with you in terms of schedule changes, but I think the most important thing is that patients need to identify to their doctor as soon as possible that they're experiencing signs or symptoms related to neuropathy with this drug. And the earlier one can identify that, and the earlier one can modify the administration of the drug, the more likely it is that the individual is going to be successful in being able to stave off the neuropathy. Now, having said that, the rare and occasional patient that I've had, went to bed at night feeling good and woke up the next morning with neuropathy. And so one has to recognize that there is going to be this individual patient once in a while that you're going to see. But by and large, being able to stay on top of the patient plays an important role. Now, one of the interesting points about identifying risk for Velcade-related neuropathy is that the risk may actually not lie with the ability of the bortezomib drug to target the proteasome. In fact, there are off-targets that now appear to be playing a bigger and bigger role, one that perhaps is not seen with other proteasome inhibitors. And I think some of these early studies that looked at genetic markers didn't take into account these other off-target locations where the bortezomib may be causing the neuropathy.
Just a question for perhaps my three colleagues. If you look at the frequency of the Velcade neuropathy, it varies, I guess, between 16 and about 36%. What's your feeling about the pre-existence of the neuropathic difficulties? Are you simply adding on to it, piling on with Velcade? And if so, should there be more intensive screening, either self-administered or doctor-administered screening for these people?
I think one of the most common scenario I see is the patient who's underlying diabetes mellitus. So these patients tend to have significant neuropathy. And obviously patient, I actually shy away from patients who have already peripheral neuropathy instead of treating them. But the patient who has diabetes, we saw a fair number of these cases. So I think that's
you want to say something?
Yeah, I wanted to share with you at least some of the data that we presented at the American Society of Clinical Oncology last year, where we had over 900 patients in a series in whom we wanted to identify what the rate of neuropathy was. And when we excluded diabetes as well as treatment-related neuropathy, we came up with a figure of about 22% of the patients having disease-related neuropathy. So it's an important concern in our community. Now, what was even more surprising in that study is when we went and looked at impact of different therapeutics on the underlying Waldenstrom's neuropathy. Surprisingly, guess what drugs came ahead? Velcade, as well as thalidomide. And that may have to do with the fact that these drugs are able to reduce down the IgM to a level that allows for the nerve to start healing. Now, like Rafat has told you, I fully agree. It's very hard to rationalize giving a drug that has neuropathic tendencies only to make another neuropathy go away. But it is also instrumental in teaching us that being able to knock down the IgM in these patients to the lowest possible level with these novel agents actually has some basis. And so maybe drugs like carfilzomib and others that have less neuropathy associated with them, may get us to that point.
Yes, I would simply add that there was a study several years ago of persons above the age of 70 years who had no symptoms or findings of peripheral neuropathy. But when EMG studies were done on those individual patients, that slowing of nerve conduction was seen in about a quarter of them, suggesting that aging can be associated with peripheral neuropathy. And I think that these are the patients who get symptoms of peripheral neuropathy very soon after they begin a neurotoxic drug. And it's very important to recognize patients. We aren't going to go out and do EMG studies on you because you wouldn't be very happy before each treatment, but it's something that clinically needs to be taken into consideration. And as we're speaking about that, Dr. Hochberg, we have a question that's directed to you. What is the mechanism for excess IgM to cause peripheral neuropathy?
So the best data, the most visually interesting data, come from the French who have actually done electron microscopy of myelinated nerves and demonstrated that the IgM deposits in the jelly roll of insulation surrounding the nerve, unwraps the jelly roll, releases materials into the bloodstream from the jelly roll, and then, as a consequence, the electrical cables now crosstalk one cable to the next, so you get short-circuiting, which is identified either as pain or tingling or numbness. The process of repair involves reconstructing the insulating cable around this electrical wire that's in the center of it. So that's true for the big fiber neuropathies. A little bit less clear is what happens to the tiny little twigs that are the isolated copper cables without insulation, the so-called axons that are down on the surface of the skin or a variety of organs. And nobody yet has demonstrated that the IgM is fixed to the axons. Probably that simply represents a difficulty in doing the actual study, because to identify a single axon and then stain it for IgM is really a feat. But one of the issues, of course, is going to be to try to develop very small skin biopsies which can then be sectioned, find the individual nerves, and develop the staining for IgM in them. I suspect that there's IgM deposition on these axons as well, but it's just not been well studied. That's particularly important because if you think about a copper cable that doesn't need insulation, then theoretically the repair process should be a lot quicker for these axons if you knew that the IgM was being deposited on them. get rid of the IgM, the axons will resprout. They don't need to have this jelly roll reconfigured. So that's a large part of it. There may be other targets for IgM. And in general, there's deposition of IgM in blood vessels. So one wonders about the effect of IgM that's circulating, not pentameric IgM, not clotting IgM, but affixed to the blood vessels to damage these very small nerve tribunes.
One of the interesting outcomes of the Harvard Neuropathy Consortium that we've had is this debate about how to best diagnose individuals that have the IgM-related neuropathies. And both Fred and I are not big fans of nerve biopsies because they can be quite painful and maybe not even informative. But some of the letdowns that we've also had is attempts to use skin biopsies, because by and large, as you've reminded me as well as other colleagues, myelin or jelly roll is really, for the most part, missing as the nerve actually gets close to the terminus. In the end, you don't really see that. So it becomes really hard to make a good diagnostic test out of being able to do skin biopsies. And I was wondering what your thoughts are, perhaps reflecting on other technologies, how we can go about doing this without inflicting more suffering on our patients.
Unless, Morrie or Rafat, do you have?
No, I have a question for you.
Okay. So one of the things that I think will hopefully emerge is a set of visualizable scanning approaches for nerve. This gets a little complicated, but the nerve terminals in brain or in the peripheral nerve are lined up, and the water in them is lined up as well, and you can visualize the water very well. So in effect, you can use magnetic scanning to visualize the nerve and the individual water-containing nerve fibers. So this technique for magnetic scanning, which is called tractography, T-R-A-C-T, is an elegant coming approach to look at nerves, and you will very shortly see not brain MRIs or spinal cord MRIs, but MRs devoted to the individual nerve fibers, with a resolution probably now at about 1 millimeter, but theoretically improving over time. So if you think out of the box for a second, you can imagine a world occurring where you can actually link that particular technology to visualization of IgM deposition. So there are techniques for molecular imaging where you can find IgM deposition, and you can actually identify the relationship between nerve and IgM deposition. So I would view the development of tractography as a major boon to the 3/4 of people here who say, I'm not going to have a biopsy, I'm not going to have electrical studies, I want a non-invasive approach to follow it. So that's where things are going to get very interesting quickly.